Okay, I think we got everybody from the waiting room, so let's get things started. We have lots to discuss, lots to cover, and I want to obviously thank everybody for joining us this evening over dinner, over drinks, if you're like Dr. Lin, obviously, as we can see in his background. But I think tonight will be more of an informal discussion. Obviously, we do have some content that'll be shared by our excellent two presenters. We'll have lots of time as usual for Q&A. And then I'll take, 5 minutes as there are certainly some next steps that we are able to take after discussions like tonight about vaccines and diabetes care. And we hope that whether it's just the ingraining of more medical knowledge, a pathway that's to be created, ongoing discussions, between endocrinologists, pharmacists, allied healthcare professionals, all obviously, for the sake of furthering patient care, as we're a lucky group at LMC. And of course, even at Ciendo, where Sue works as well. So to get things started, I'll introduce our first speaker, Dr. Lin. Since Dr. Lin is an extremely busy individual, we're going to take Q&A after his presentation. Then he has to run, but I'll text him if any other questions come in after that. Then Sue will present, we'll take Q&A, and then we'll obviously wrap things up by 8:30. So Dr. Peter Lin is no stranger to LMC, certainly an honorary LMCer at this point, helping us co-chair our many primary care events for the last 8 years. He's also the director of the primary care initiatives at the Canadian Heart and Research Center. He's the contributing author to the Canadian Diabetes Guidelines in 2013 to 2018. He's, of course, spent the last several decades bridging the gap between education and primary care and, of course, research and clinical care. And we're very lucky to, of course, have him speak to us about what many might consider a primary care topic in vaccines and diabetes. And we'll pass it to you, Peter.
Great. Thanks very much, Alex. So thank you all for joining. And I feel kind of honored because it's like opening for Taylor Swift, because when Sue comes up, she's going to give you the meat of the thing. But what I'm going to do is I'm going to talk to you about vaccinations and just general kind of stuff and go over some of the data as well. So this is the picture that I hope that you guys have, or that you're seeing. I'm sure every one of us wants to be here. But if we vaccinate our patients, we can make our lives easier and make the patients' lives easier. They don't get sick. They don't have to end up in hospital. Less work for us. So think of vaccination as a way to decrease your own workload for your patients. These are my conflict of interest. So I've worked with all these companies before in education. I don't do it in clinical trials, and I don't own any patents. And this evening, we want to thank GSK for allowing us to get together. And I will be talking about some of their products in the vaccine area. I thought I'd start off with this. This is the COVID shot, the coronavirus shot. So I wish it was like that. I think COVID has kind of made people not like shots so much, because the thought is now you have to get it every 6 months. So of course we know that with shingles and things like that, it's a very long lasting. So we actually almost have to remind people that the old vaccines that we have are actually quite good. We don't have to keep doing this every 6 months or 3 months. And so I think we need to remind our patients that it can do some good work. I'm going to talk to you a little bit about RSV and zoster. We'll talk about why, as we get older, we have problems, what the disease burden of these things, what kind of vaccines are we talking about, and a little bit of the clinical trial data that is evolving right now for RSV for sure. So when you're talking about young kids, their immune system is naive. So therefore, their T cells are not really well trained. And then as you get older, basically now it becomes sluggish. So why does it become sluggish? One possibility is your thymus, okay? So the T in T cell stands for thymus. Now, the T cells are made in the bone marrow, but basically they go to training school in the thymus. So it's kind of like Harry Potter going to Hogwarts, and basically they're getting their training there. And basically there's two things that it has to be trained upon. One is to make a receptor that can find something useful, like identify measles or something like that. And so basically what we do is we take the building blocks and we reassemble them. Kind of like if I give you a whole bunch of Lego blocks and then you reassemble it in different ways so that you can make receptors that might be useful for you. So if you make a receptor that's useful, then that T cell is kept. Otherwise, the T cell is killed. So this is like the Hunger Games, a different movie. So the idea is that you want to make a useful T cell. The second thing is that receptor cannot recognize self, because if it recognizes your own HLA, then all of a sudden you're going to attack yourself, and that would be autoimmune disease. So if it recognizes itself, those T cells are killed as well. So of 100 T cells that come in, only 2% graduate. So 2% is the number of T cells that come out, and therefore they're very good. They're trained. And so therefore they can recognize things quickly. So if a virus comes and attacks you and you can recognize it, you can mount a response quickly. If you cannot do that, then it's a problem. The virus will win because it'll grow faster than you can knock it out. Unfortunately, by the age of 60 in Denmark, they did all these scans of people. Our thymus is now replaced mainly by fat. And so just like the rest of my body is full of fat, and so therefore your thymus is replaced by fat. So there's no more training. So you're still making T cells, but they're not getting those specialized receptors. So therefore they cannot respond as quickly. And so that's why older people, when they get an infection, it's sluggish in terms of the response, and the virus will grow faster. Therefore, they get into a whole lot more trouble. And that's why we have to take over the training with vaccination. So we can't train it for everything. So what we do is we inject little things into you and say, look, here's RSV, here's shingles. Please recognize and make your defenses. So really, we're taking over the role of the thymus training because now the thymus is no longer there. And I find that patients, when they understand that, then they don't mind the multiple injections that we're asking them to do because we're actually training their immune system. In terms of the vaccines, I've just listed a whole bunch of these things here. I'll make these slides available to you, but these are all the vaccines that for adults we need. And here's another page full of them, and that continues to increase. And if you're traveling, there's all sorts of different chikungunya vaccines and things like that you have to look at. And here's just a pictorial representation of these viruses and bacteria that we can take care of. For tonight, let's just talk about pneumococcal disease, shingles, and RSV, because that's where things have been changing the most. For pneumococcus, as you know, that it has those proteins as well, but the pneumococcus hides in this area by putting polysaccharide layer around itself. And so therefore you cannot recognize it very easily because we have a lot of polysaccharides, proteins that we have that's normal to our body. And so the hope is that the bacteria can hide its way and go and infect you. And so therefore this capsule is what we try to recognize these different polysaccharides. And so therefore initially we had the Prevnar or the Pneumovax 23 to recognize 23 of those polysaccharides. But then whenever you just use saccharides, it doesn't stimulate the immune system as much. So therefore, if we can put it with a protein, if we can conjugate that polysaccharide onto a protein, then you'll make it much more reactive. And so therefore, Prevnar 13 was the first one where they put a whole 13 of these polysaccharides on top of a protein. And therefore, it was very helpful for kids because their immune system would then be stimulated appropriately. And so this was Prevnar 13. Then they went on to the 15, and they just kept adding things along the way. We're right now at Prevnar 20, where they've kept all the old ones and added new ones on top of there. And of course, the hope is that we would protect more and more people. So here's Prevnar 13, the number of protected. Here's 15, here's 20. So we're increasing the number of serotypes that we're protecting that are the invasive types. And so therefore we can help protect people that way. However, the Merck folks have now sort of deviated from the strategy of keep adding on. And what they've done is they've deleted off some of them. Okay, so now we've got 11 extra ones over here that are special. And then you've got a whole bunch of them that they've deleted. And the thought process is that these ones are no longer prominent. And so therefore, why do we want your body to make antibodies and all those things against that? It's actually a bit of waste of resources. So we've been shifting this thing depending on the types of bacteria that's floating around. So you may see that this is 20. And this is known as 21, but it's not really just one more extra. They've actually shifted it across. Currently, this one is covered. So Prevnar 20 is covered. This one is not covered. So depending on what NACI recommends, if this thing becomes covered, you may say that, you know, you got Prevnar before, but we want you to get this one as well because it's covering different things. So I just wanted you to be aware that 20 and 21 is not missing one new one. It's actually a whole stream that might be different as well. So you might see some different things. So perhaps next year, Alex can invite us back and then we can give you that portion of it. And here with the extra ones that we're talking about, you're now covering 81% of them because it's shifted to cover the most prevalent invasive versions. The other things that we're going to talk about is RSV, which is a virus that attacks you from the outside. And shingles is a virus that attacks you from the inside, but the strategy is the same. Let's talk about RSV. So RSV, an angry virus, we all know that these viruses have a set of keys. So this is the set of keys. They have a set of blueprints. The set of keys will allow them to get into your cells so that they can replicate themselves and then propagate that way. They don't have any equipment on their own. They just carry blueprints and a set of keys. Interestingly, the RSV virus can go into the cell and make copies of itself, but it can also put those set of keys on the outside of your lung cell. And therefore, this thing can now fuse with this one. And therefore, this can actually create a syncytium. And that's why it's called respiratory syncytial virus, because it can create these blobs of cells that are connected together. And this is not unique to RSV. COVID does the same thing. COVID goes into your cell, makes the spike protein onto your lung cell. The lung cell spike protein attaches to ACE2 on the next lung cell, and they fuse together to be a giant lung cell. In the case of COVID, the giant lung cell will eat away lymphocytes. And so that's why originally the lymphocyte counts were very low and the patients were having a hard time fighting off this particular infection of COVID. Delta is the most fusibility in terms of eating away your lymphocytes. Omicron is the least likely to fuse. So that's why now we're in the Omicron phase. And so therefore the severity of the disease is not that bad. But if we move back to something that fuses very well and eats away lymphocytes, you're going to see more people ending up in the ICU again. But this concept of fusing has been there since the RSV virus. And the problem with this respiratory syncytial virus, they don't eat your lymphocytes, but these blobs end up plugging up airways. So if you have COPD, you now have these blobs of cells, and it's now very hard to breathe. If you're a little kid with the small tubes, you're going to plug up the tubes and you can't breathe. So that's why when you look at hospitalization, it's the little kids, they plug up, they can't breathe anymore. And as their tubes get bigger, you can see that the hospitalization rate comes down. And then what we see is in the seniors, all of a sudden it goes back up. This is a tenfold increase, not because their tubes are getting small, it's because their immune system is no longer able to fight quickly, and therefore they're getting into trouble. So we have two bumps, one in the young people and one in the very old. And when we look at the young people, people always say, why don't we have a vaccine for them? We tried. So in 1967, they had a kids vaccine for RSV, and it was formalin inactivated virus. That was the only technology they had. So whole virus, inactivate, fire that into the kids. Unfortunately, it made things worse. When the kids really exposed themselves to RSV, 80% of them were hospitalized and 2 died. And most likely it's because they showed the immune system a dead virus. And so therefore the child's immune system that's developing said, oh, we don't have to pay attention to that guy because he's not doing anything. So when they actually saw the real virus, they said, oh, I know this guy, he's not harmful. So the body never mounted a response, and that's why they did poorly. If the kid had RSV and then got the vaccine, the kid knew that the virus is bad, got the vaccine, that was helpful. But that would mean that you have to be infected before the vaccine works. So they stopped all vaccinations for children, no more program for RSV vaccination for kids. So instead, what they said, let's give them antibodies. So this is the antibody that they give for the last 20 years, because we just provide them with the army as opposed to giving them the shot. And so therefore, monthly injections of the monoclonal antibodies, and only to very sick children, very expensive strategy to go. Recently, we have a new monoclonal antibody, and this one has just been approved. Beyfortus is the brand name from Sanofi. And the good news about this one, it's a single dose. They changed some amino acids here, so now the antibody lasts for a long time. So just one shot for the dose of the season, and all infants can be given, because their studies were in healthy infants. And that's because hospitalization for RSV, 80% of the kids are healthy. So therefore, this would cover most of them. So therefore, you don't see this anymore. And the reason why I'm explaining all this kiddie stuff to you is because the moment you say RSV, your patients will have all sorts of weird questions. So I want you to have the broadest knowledge base so that you can answer those questions very effectively. So children, we always give antibodies. We never give them a vaccine. The other option that we could do is give a vaccine to the mother. So if we give them a vaccine, then basically they will make antibodies and then pass it on to the baby. So at 32 to 36 weeks gestation, they can get an RSV vaccine. This is the Pfizer one, Abrysvo. So basically they will get that shot, they'll make the antibodies and then pass it on to the baby. So again, the baby only ever gets antibodies. So between the two of these ones, which should we choose? So the NACI guidelines did a very good analysis of hospitalization for the antibody. And this is the reductions that we're seeing, 80 to 90% hospitalization reduction. Whereas if you're talking about the injection for the mother, it's more like the 40 to 50%. And so it was very clear that they recommend the antibody would be the best choice for the babies. So you give it to the baby. If they cannot get this, let's say they're going to be out of the country or something like that when they deliver, then you can use this option. But you can imagine problems here if they were vaccinated at 30, let's say 4 weeks, and then there's only 2 weeks left. Is there enough time to make antibodies? Or if they deliver early, did they make enough, so on and so forth. So the NACI recommendation here in Canada is to use the monoclonal antibodies for the babies. Is it safe? These are the profiles for the antibodies, quite safe. And if you look at the sick children with congenital heart disease, similar safety profile. So you can use it for healthy and sick children. And then for the patients that will be asking you, when is RSV season? It's during these months. And so if the babies are born now, they will get that monoclonal at the hospital. If they were born before the season started, they will be given a shot either by public health or their family physician. And so this shot is the monoclonal antibodies. It's not a vaccine or anything like that. So just in case people ask, and there's two different strengths. And then, of course, in second season for your very sick people, you would give them a higher dose. You don't need to know all of this, but just in case you start talking about RSV, people may have questions about that. For the seniors, where did we get into that? So these are the people that are young that get to hospital. So this is the seniors that are into hospital. And that wasn't very impressive, but the death rates was impressive. Kids do not die, thankfully, but the seniors die. And to show you the number in a different way, if there's 1,000 kids in hospital with RSV, one will die. If you have 9 seniors in hospital with RSV, one will die. And so this number was too high, and we don't have any antivirals for RSV. So therefore, vaccination seemed the most, straightforward strategy for these particular people. Now, let's say you don't die and you survive your RSV. What happens to you 6 months later? And so when they looked at that, basically about 1 in 3 people have lower functional status. So they're not the same as before. And number 2 is that 8% of the people no longer can live on their own. So they need somebody to live with them, or they have to go into a nursing home. And so again, even if you don't die from it, the downstream effects are bad. So therefore, vaccination ahead of time would seem to make the most sense. To design the vaccine, you know about these proteins. The only difference is that there's an attachment protein, G, and that's different between RSV-A and RSV-B. And then there's the fusion protein, which is roughly the same, like 95% the same. And so which one would you target? You would target this one because it's easier to cover both of them. And so in the GSK one, they just took the A one, which is about 95% the same as that. And so that's what they have in their vaccine. The Pfizer one has both of them mixed in there as well. So realistically, it doesn't really matter because it's so similar between the two of those. But you might hear them talk about bivalent, and that's all it means, is that they took both, versus monovalent, which is just a one, but they're both very similar. If you inject this thing, and it's going to be called RSV pre-fusion, so before that protein sticks to you, that's the one that it's attacking. If you inject it in young people, you make lots of T cells. If you inject it in older people, you make, but not as many T cells. So then that got people thinking maybe we should add an adjuvant so that we get the immune system to pay attention. So adjuvants sort of create a local kerfuffle, and therefore your immune system makes sure that they pay attention to this little protein that we're injecting. And that's really all they're injecting. So this isn't the whole virus. This is not mRNA. It's just that little F fusion protein that they're injecting into people. So maybe an adjuvant is useful. For GSK, their adjuvant, which is the same one that's in Shingrix, did a good job. It boosted up the immunity. For Pfizer, they tried it with their adjuvant, and it didn't help. So therefore, they didn't put in an adjuvant because it didn't help their vaccine. And so for the Pfizer one, there's no adjuvant. For the GSK one, there is an adjuvant as well. And the reason why I'm saying the company names is because the actual names of the vaccines sound very similar. So I figure the company names are easier to separate them out. In terms of the side effect, this is the GSK one, Arexvy. And so basically, it's the same adjuvant as in Shingrix, so for the shingle shot. So therefore, it's nothing freaky. The only difference is that the adjuvant is half the amount. So if anything, it's going to be less. So for patients that have had their shingle shot, you tell them this one is just like that one, except half the amount that's sitting as the adjuvant. And so you have some local symptoms, some systemic symptoms, nothing really crazy. Nothing weird in terms of severe side effects or anything like that. So basically fairly well tolerated for our patients. So let's look at the studies themselves. And the only thing I wanted you to think about is the two names are very similar, Abrezvo and Arexvy. So the X, okay, so one has an X in it and one has a Y in it. Okay, and I'll show you that in a second. And so here what we do is shot versus no shot, 25,000 people. And then what you do is you can tell me whether the shot works or not. And in season 2, we re-randomize them into shot or no shot. This is, do I need a booster at the end of the first year? And then you follow them out to 3 years to see whether you need to boost or whether it's staying quite stable. And so this is the results that you see here. So in season 1, what did you get?
Just to give you a framework, to get approved, you just need 20% benefit. So if you can show a 20% reduction, that's enough to get approval. That's very much like statins, right? If you reduce MIs by 20%, then you get approved. So vaccines, actually, the target is not that high. Now, thankfully, if you look at the bad stuff, which is the lower respiratory tract infection kind of things, what you see here is that basically it was quite good, 82% vaccine efficacy. And so therefore, that would be quite good protection for your people. The second question people had is, what about if you had comorbidities, like the sicker people, people with diabetes, heart disease, heart failure, those kinds of things? Did they do as well as the general population, or did they do worse, right? Because our expectation was that they're going to do worse. Thankfully, they actually did better. So the vaccine efficacy was improved in this sort of sicker people. And that kind of makes sense, right? If I give you the vaccine with the adjuvant and everything, you get a heads up. And so therefore you're ready for this. And so therefore that might actually be better for you. What about the severe version of the RSV, like the really bad one, ventilators and that kind of stuff? And here we see also a very high number in terms of vaccine efficacy. So overall, very good for season 1. Season 2 data is sitting here, and I'll show you season 3 in a second. So season 2 data is what happens in that second year. And you could see if they had comorbidities, 73% protection. If for severe disease, 78%, well above the 20%. So no need for booster after the second year. It's for the second year. Now, what about the one from Pfizer? That's the Abrezvo. So that's the Y sitting in the middle. And so for them, it's a little different design. So shot versus no shot, also a very large study, but there's no boostering. So in other words, it's one shot, and then they just go out to season 2 to see how well that one shot does. And they broke it down into people with more than 2 symptoms or more than 3 symptoms. So these would be the sicker people in the study population. And so here's the same profile. So the people with 2 or more symptoms, the protection was 66%. And then if you look at 3 or more, so the sicker people, then you get a little higher protection, which is good, right? So the sicker people or the sicker version of the disease is you're more protected against. Now, what about in terms for the severe RSV? They didn't have enough numbers, so I can't show you that bar about the severe cases. They just didn't have enough. What about people with pre-existing conditions? So remember the last study, the people with pre-existing conditions actually did better than the general population. So what about within this study? We don't like to compare between studies, but I think it's okay to compare within a study what that population did. So if we compare the comorbid patients here in terms of 2 symptoms, can we beat this 66%? And unfortunately, it's 62%. And what about for the 3 symptoms, coexisting disease? Can we beat the 85%? And the answer is it's 75%. So in this particular study, when we look at the sicker people within this trial, they seem to be slightly less beneficial than the overall population, whereas the other one, they seem to actually have higher protection. So that might be useful for us as we're considering things. Here, they do have 2-year data, but they haven't published it yet. So I've got 16-month data for you. And so here, the 2 symptoms is about 58%. And then 3 symptoms is 81%. So again, both are above 20%. So no recommendation for booster at this moment. Now, GSK just got 3 seasons. So Sue was good enough to send me some of these slides. And so this is the poster presentation. And what the company has done is put it back into that time frame of how we looked at it. So they put it in this fashion. So this is season 1. I showed you that already. What is the season 3? So if you look at all 3 seasons rolled together, and here are the numbers. So this is looking at the lower respiratory tract infection, 69% protection. And then if you're looking at people with comorbidities, and again, we see it slightly better. So that's always a reassuring thing that the sicker people are doing well. And this is the severe version. And again, they're doing well. So again, above the 20%, no need for recommendation for revaccination. So it looks like it's holding its own, and perhaps it'll go out. And I'll also show you the shingles data. You know, it's going out to 10 years. I don't know if it's going to go out to 10 years, but at least now for 3 years, it's quite good. So you don't have to keep getting annual shots. And I'm hoping the government will see this as a good cost saving. So if now you can divide by 3 the cost, then maybe they'll start covering it for more people. Now, this data is just out like within the last week and a half or so. So therefore, it'll percolate its way through the government system, and maybe they will announce something a little later on. The NACI recommendation before the 3-year data came out was very simple. RSV for over 60 people. And so they had some strong recommendation. If you're over 75 and you have increased risk, then you must catch those people. So in your clinics, if you see a 75-year-old diabetes, that kind of stuff, that one, we shouldn't let them go away. If they're in a nursing home situation and they're over 60, they're high risk. So we should make sure that they get covered. For people that are relatively healthy between 60 and 74, then we can, if we miss them today, that's okay. But for that group at the top, we definitely should not miss them. But this one also qualifies. So easy way to think about it, over 60, everybody can get it. But here are the people that we must not miss at all. Dosage right now, no recommendation for booster. Can you administer it with other things? They say yes, you can give it with a flu shot. And they've actually done studies looking at that. But NACI is very safe. They said if you can wait, then separate some time between these new vaccines and the old ones, but you are able to give them together if you wish. In Alberta coverage, so where Sue is from, so they just announced that October 21st, they're going to be covering it. And you'll see here, this is the one with the Y, so that's the Pfizer one that they're covering. So I think based on the cost, they were coming in at a cheaper rate. But if you look at the data, I would have thought maybe they go the other way because the sicker people were doing better. So for this year, it'll be that. And then it'll be anybody in a nursing home, so over 60 in a nursing home setting. Or if you're in a community setting and you're over 75, they're covering. So their commentary is that there's limited supply, so they want to cover the sickest people first, and then they'll hopefully branch out later as well. In Ontario here, basically it's publicly funded for people over the age of 60 who are in one of these things. So long-term care, dialysis, stem cell transplant, those kinds of patients, homeless people, First Nations people, they're all covered under our provincial system. And again, this year it's a Breezeville. Last year it was a Rexv, so there's still some of that supply there. So that will be used first. So that's the one with the better results in the comorbid people. But then after that, it'll be the Pfizer one that will be sitting in their storages that you're using. Shingles, let me spend some moments on this. So this one, you guys know it's chickenpox, basically, right? Reactivated. And so when you got chickenpox, it was an airborne disease, and then it went in and it became a systemic disease through your blood. So it was a viremia that was spreading around. And when the virus got into a dead end, like the capillaries, it couldn't go anywhere else, so that it settled out in your skin and it started to make all these blisters. And we used to have chickenpox parties to get, everybody together to pick up the chickenpox from little Johnny. At that time, we didn't realize that the chickenpox virus can get into your nervous tissue. So if it can get into the ganglion, then it can stay there. And once viruses can get into nervous tissue, it's relatively protected because the antibodies are too large. They can't follow it into a cell. And number two, the only way to get rid of that virus is to kill the cell. So your T killer cells would have to kill a neuron. And most T killer cells will not kill a neuron because neurons are very precious. So that's why once it enters into nervous tissue, it has a safe haven that's sitting there. Same thing with COVID. Once it gets into nervous tissue, antibodies can't go in. T cells are unlikely to kill the brain cells. So therefore, they have a safe haven. We're not exactly sure why, but when you're under stress, attack, when you've worked too hard, all of a sudden your body goes into defense mode and it starts producing a lot of proteins. And unfortunately, it grabs the blueprints for the shingles virus and it starts to manufacture the proteins of shingles. And then you get the viruses replicating. So it's not so much that the virus is sitting there and say, I'm going to start replicating. It's something makes your cells do this. And Sue will go through all the comorbidities and things like that may trigger this sort of production of proteins. And all of a sudden, you end up producing the blueprints of the virus as well. And so the virus will now go down the nerve and then go to the blistering sites here. And we used to say, but we have antivirals so we can treat this thing. But really, it's too late because the nerve has been damaged. So if you want to prevent that nerve damage, you want to vaccinate, not treat the blisters once it comes out, because once the blisters come out, you've already damaged the nerve. And so therefore, the complications, of course, is post-herpetic neuralgia, this horrible pain because you've now damaged the nerve. And the other one is eye involvement. So if it's in the V1 area here or at the tip of your nose, it means the virus could have crossed through your back of your eye. And if it replicates in there, now you have a chance of having blindness. So that's an ocular emergency. So if you see blisters here, off to the ophthalmologist, they have a look inside to see if the virus is replicating there. Ideally, we vaccinate them way ahead so that they never get these complications, right? So that we don't have to be treating these things down the road. This is my office on a Friday morning. This is actually a train station in China. So who's at risk? You guys know who's at risk, right? It's elderly. And they looked at all these different countries in terms of the incidence based on age. And you can see that young people can get it, but it's very rare. But the kickoff is somewhere around 50. So at 50, you see this spiking going up, just like with colon cancer and everything else. And presumably that's because your immune cells, your thymus and all that stuff is no longer functioning as well. So really 50 is where the cutoff is. But if you look at, oh, sorry, this one is a weird one. Okay, so I lost my graph. I'm sorry about that. So normally we think about it at 65 years of age. And the reason why we think about it at that point is because the government pays for it. Now, one time I asked the government bureaucrat, I said, why do you pick 65? And he goes, 65, they become our responsibility. In other words, at 65, they're our responsibility. So then we want them to get the vaccine and we actually give them 5 years to get it. And I thought that was a good explanation of why they're covering in this window. That means before 65, that's our responsibility in terms of coverage. So therefore, we have studies that above 50, there's very good benefit. And so therefore, this is the time that we have to remind patients. So if they have diabetes and this, then we have to remind them that, hey, you need to, you're qualified for it. Don't wait the 15 years because that's a long time and you may get shingles in between. For the people that are older, in other words, over 70, they're not covered. And I tell them you're at very high risk, so you'll have to pay for it. We'll say the government's terrible, they don't pay for it. We yell at the government, we complain, and then they go, okay. And usually the grandkids or somebody will pay for it so that they're covered. So patients will have to pay in this particular area. Now, if I get somebody young to get it, they get very good protection. If I get somebody old to get it, they also get very good protection. So 90+%. And what about the side effects? So the younger people have a bit more side effects, the older people a little bit less. I tell them don't go build decks, just take it easy for a couple of days. And the post-herpetic neuralgia is reduced by almost 90%. So in the past, I used to tell people, if you take this shot, you will not get shingles. But the Zostavax, which is the whole virus, was horrible. It was only 50%. And that's because I'm showing you the whole virus. And you don't know what's important. So you make antibodies against everything. And so you don't really know what to keep. So for the whole virus, the protection goes down quite quickly. And so therefore people were getting shingles and they would yell at me, you told me I wouldn't get shingles and now I got shingles. So now what I say to them, if you take this shot, 90% reduction in your chance of getting shingles. And even if you do get shingles, the chance of you getting that painful thing is reduced by 90%. So a 90 and a 90, most patients will say that's a good deal. And you now have data that looks at the super old people and they're doing well. In terms of coverage in Ontario, for example, you could see here that the coverage is between 65 and 70. However, because of the pandemic, they've extended it because a lot of people missed it. So now, even if you're born in 1949, you would still qualify and you can still get it up until the end of this year. So I tell patients it's still on sale. So you can go ahead and get it. And that's actually a good deal that you just jump at it. Immunocompromised, we never talked to you about immunocompromised people because the last vaccine was a whole virus. So we can't give a whole virus to an immunocompromised person because it might grow in their body. But now that the shingles is just the E protein plus the adjuvant, we can use this in immunocompromised. And so basically, this was a high-risk population. So this is data from Spain where they spread them out over age categories. This is people with a good immune system. You could see it increasing with age. And then what about with a bad immune system? You could see that it is increasing with age, but much worse. So look at this 80-year-old plus, you're talking about doubling the effect of just having an immunological problem. But the real concern is these younger people. Like let's say this group, there's their baseline risk, and now it's going up to here. So that's a 20-fold increase in their risk. So the Health Canada people said, you know what, we need to protect them. And now that it's just a protein, we can give it to these people. So they said to, the GSK folks, do some studies, right? In people that can live long enough, show us vaccine efficacy, like less shingles. In people that don't live long enough, show us that the antibody levels go up and that the side effect is very reasonable. And so they went off and they did all of this kind of stuff, right? They said, okay, let's look at HIV, let's look at stem cells, let's look at hematologic malignancy, renal transplant, and solid tumors. And you can see some are for efficacy, some are for just antibody titers and everything else. And so by that collection of data, basically Health Canada said, that's good enough for us to be able to protect all of these patients that we're talking about sitting here. And so now if you look at this little graph, we now look at it as being people that are over the age of 18, you can now use this. So immunocompromised people over the age of 18, you will be able to use the vaccine based on all of those studies. So now all of a sudden, the whole spectrum, just basically if you're an adult, we should be thinking about shingles vaccination. You would fit into one of these pockets. The dosing, you guys know, it's one dose here, and then the next one is between 2 and 6 months. If you are getting somebody that's going to get immunocompromised soon, like let's say they're going to get some therapy, you can actually speed that up as well. And if you miss a dose, let's say they don't come back for the second one and it's a year later, NACI has said just give that shot whenever. You don't have to restart everything, because all you're doing is you're now just giving a little top up. So the first shot is actually quite good. The second shot is just to make sure you top up so that you can last for a long time. So whenever they come in, they should get that shot as easy as that. What about if you had shingles? Here's where the recommendation in Canada and the US is different. So in Canada, they said if you had shingles, then wait at least a year to get your shot. And the reason for that is very simple, is that you just went through shingles. So is your body really going to pay attention to this little tiny protein I inject into you? Probably not. And so therefore the effect of the shot may not be there. Number two is if we hyperstimulate you, in other words, you just had it, I give you a shot, I stimulate you again, could we then have you react in a bad way? Because we've seen that with other vaccines in the past. Multiple injections too close could actually overstimulate your immune system. So by waiting that year, your risk of shingles during that year, if you just had it, is very low. You're not going to get it again. And the risk of getting rid of those other things is much higher. In the US, they just say as soon as your symptoms clear, you can get the shot. But I think our Canadian one is more thoughtful in that, does the first shot work if you just went through shingles? So here, just wait a year. And then those people are very motivated to make sure they get done. Oh, this is family history. So I love these two little kids. So if you have a family history of shingles, so first degree relative, which means your parents, your kids, or your siblings, if you have first degree relative with it, then you're at 3 to 5 times the risk of developing shingles yourself, because your immune system might be like theirs. And the other thing is, I don't know what happened in Italy, so there was no increased risk based on relatives. Maybe they're all related or it's the alcohol, but everywhere else there's a 4 to 5 times increase. If you have multiple relatives, then you're looking at 13 to 17 times increase. So a short family history is useful. And also once people hear, yeah, I remember my brother had shingles, it was terrible, then they're more motivated to get vaccination as well. So therefore that's a good way to get them motivated. The other thing about family is that we're now vaccinating kids, so there's no more chicken pox. So that means the parents and the grandparents are not getting that little exposure of chicken pox when the kids got it. So when the kids got it, you got a little dose of chicken pox, your body says, I remember this bad guy. I'm going to beef up my immune. So it's almost like an inoculation from your children. So therefore, because the kids are not getting it, shingles is going to go up in the adult population. So that's why we want to get people vaccinated as well, because they're not getting exposed to the kids with chickenpox. Their own personal risk is going to go up. Now, overall, this is a good system, right? Because eventually the kids will never get shingles because they've never had chickenpox. So we will be getting rid of chickenpox and shingles forever. But unfortunately, during this time, we just have to be careful that they're not getting auto boosting. So we're going to have to help them with the shot in this case. How many boosters did you say you had? This was during the COVID time, where you're supposed to get one every 3 months. And so here's the data for that. This is the original trial data, and you can see very good protection. They continue to follow these people out every year. They will give you another year's worth of data. We're now just at 11 years. So next year I can show you one more slide. That'll be the best CME ever. It's just one slide. So here's out to 11 years, and you can see the protection is still quite good. Here's the absolute numbers, very low in the side that got vaccinated. So the protection continues on. And depending on what age you got the shot, it's also very good protection still. So don't worry that if somebody got it at 50, like, are they going to run out? And there's a study that says at 10 years later, if I give you a shot, we can send everything back up. So if at any point we need a booster, it'll be there. So therefore, the recommendation is no booster needed for shingles. And we're tracking those people out. So for your patients that are getting it now, you can tell them, we'll know what happens to those people that are 11 years ahead of you. And that's very reassuring to patients. Now, one of the doctors asked me, are you sure you don't need a booster? I said, GSK would love to sell you a booster, right? Like that would be fantastic. And after 10 years, there's no shame in that. So when the company tells you you don't need a booster, it really means that the data is quite stable. Now for the RSV stuff, we're going to see, because now we're up to 3 years, maybe 4 years. Let's see how long that lasts for. And perhaps it'll be another surprise where one shot might do you for a whole bunch of years. This data I'm just going to show you from Israel. This was actually put together to say that infection with COVID is worse than the vaccine. And so anything that's orange means that there's more acute kidney injury with the infection itself. The only time that the vaccine is worse is lymph glands. Okay, so that's why if you get the shot, it goes to your lymph glands, it gets big. We don't do mammograms after that because of that reason for 6 weeks. And so I can't fix that one. But this one is the one that I'm concerned about. So after COVID infection, shots, there's an actual increase in shingles. And we've seen that. Okay, so physicians have seen that. So perhaps if we were sequencing this, we would do the shingle shot first, do as much as I can to protect you, and then you get the COVID vaccine. So if we can sequence it that way, that's just me talking. There's no study. It's just I want to feel like I've done as much as I can to avoid this little blip of this COVID vaccine. To summarize very quickly this section, prevention, it's an inside job. Shingles is people that have had shingles are very willing to get the shot. Those are the ones that you have to say, wait a little bit. Family history, they're very motivated to get a shot. If they've already had the whole virus, you can tell them you're upgrading them to a new shot. So you go from 50% protection to 90% protection. So that's a good deal. Immunocompromised, you now know all about that. Heart failure, COPD, diabetes. Sue is going to explain all of that to you in terms of these people are at very high risk, and she has wonderful data to show you. And then for my personal opinion, maybe before a COVID shot, in other words, get that one done. That might be helpful. And if you look at your patient population, basically every adult, you want to think, do they fit into one of these buckets? So above 50 is just anybody, that would qualify for it. And then immunocompromised would be in this section. And some people say diabetes plus all these other conditions makes them immunocompromised, but just have a thought about these people because if we can prevent disease in them, that would be very helpful. Let me just give you a couple of seconds on COVID, because I know we're all concerned about that. So back 8 months ago, when they were trying to design a vaccine, it was JN.1. So Novo Pharm was doing the JN.1. That's the one with the protein and the adjuvant. So it takes a long time to make the protein. So they cannot change very quickly. Unfortunately, the virus did change. And so therefore, the virus became KP.2. And so the mRNA technology people, so Moderna and Pfizer, were then told by the FDA, make a KP.2 version of the vaccine for this fall. Unfortunately, the virus then became KP.3. These two guys got together to make XEC. Anytime you see the letter X, it means two viruses came together to swap material and create the new virus. And this one has now made XEK. And so therefore, we're here with the vaccine, and these are the viruses that are moving around. Now, don't despair, because remember, the ACE2 receptor is what we have to attach to. The virus has to attach to this thing. And so therefore, even though the spike protein is changing, this attachment point cannot change all that much. Otherwise, it's not going to work as a key to get into your cells. So even though we say the spike protein has changed 30 amino acids, this thing is 1,273 amino acids. So there's a lot of other targets that we can hit. So even if the vaccine is not perfectly matched, as long as we're making antibodies to the common portion, that might actually be more useful for future versions as well. So for your sick people, the COVID vaccine is still a useful thing. And to summarize, finally, just this last little bit, this is on a label. It says remove child before washing. I'm not sure what happened to a child that would deserve a label like this, but nonetheless, we have to simplify things. So how do I simplify things? Shingles is an inside job, so it's inside coming out. So washing your hands won't help that. RSV is coming from the outside. We need protection from that, and the way to do it is vaccination. And for RSV infants, they always get antibodies. Either we give the antibody directly to the baby, or we give it a shot to the mom, and then the mom makes the antibody and passes it on. That's one thing that the media has gotten all wrong, because they're talking about a vaccine for kids. And so they're showing up and asking about, and just in case you start talking about RSV, and they ask you the question, it's always antibodies to the baby because of that history in the past that we talked about. So I think the goal is to get you to chase a few people for vaccination. For RSV, we used to say it's 2 years. Now with the 3-year data, maybe it's 3 years, maybe it can go to 4 years. It's looking promising. For zoster, it's 11 years plus that we're looking at. And this is my ankle. So I broke my ankle in 2010. If somebody told me in the morning of that day that they could prevent this broken ankle, I would have been eternally grateful. So when we talk about vaccines, we're trying to prevent bad things. When you're giving SGLT2 inhibitors and things like that, you're preventing bad things. When you're giving statins, you're preventing bad things. But the patients don't understand. I had this one patient on a NOAC for her atrial fibrillation, and she complained to me. She goes, I've been taking this stuff for 7 years and nothing has happened. And I said, that's the point, and that's when I realized patients don't know what we're trying to do. So now I tell patients, if the vaccine, if the, you didn't end up in hospital, you didn't have, an infection, and you didn't have a stroke, and you didn't have a heart attack, all the drugs that we're giving you, all the vaccines that we're giving you is working. And so hopefully they realize that if I get a shot and nothing happens, that's a good thing. And if I get these medications that you guys are pushing out and nothing happens, kidneys are good, heart is good, everything is good, then it means that we're successful. And I'm hoping at Christmas time, they'll realize, another Christmas and everything is good, then they'll bring you more gifts and stuff like that as well. And anyway, thank you very much for your time, and I'll stop there, and I'll take any questions if there are any.
Thanks, Peter. Great presentation, as always. Certainly a motivated primary care physician speaking about vaccines. The anticlimactic nature of it, of course, if we're waiting for nothing to happen, which is, I agree with you, Peter. That's, why some maybe, not talking about it as often. Yeah, no, we'll pause there. Any questions? The chat, I didn't notice anything. Does anybody want to ask any questions about, we're getting some applause for you, Dr. Lin. For Peter, any questions at all before he has to run off?
Sue can answer all of the other questions.
I have one question, if I may.
Please.
So I've had some young people, interestingly, who've had shingles. And so young people, one of them was type 1, another, no clue why. Possibly they had the COVID vaccine, no clue. But a year later, should these young people get the shingles vaccination?
Yeah. So if they have any immunocompromising condition, so Health Canada left it pretty loose. The answer is yes. And now they've gone all the way down to the age of 18 above. So if you're an adult, right? So that opens the way for many of our patients. So if you're type 1, I would say, well, they had an autoimmune disease to give them type 1. So therefore, and they had shingles, therefore they'll do it. Many other people would say the fact that the person had shingles says that their immune system cannot, be trusted to keep this thing in check, and therefore qualify. And I usually tell patients, I don't have a study for your age category, but what's the downside? So you get the shot, you're protected. There might be more side effects because younger people tend to react a little bit more. So that would be the only thing. And so I tell them there might be, might have to take it easy for a couple of days, those kinds of things. So in my mind, I would not hesitate to give that person who's already had shingles and they're worried about it in terms of the vaccine. I would not hesitate at all, but I would just tell them I don't have a study specifically for you, but I think it's still worthwhile.
Thank you.
Thank you. Other questions?
I think I put them to sleep. Sorry, I was supposed to get them excited.
No, I think mouths full, and maybe they're waiting for the main course, as obviously you alluded to at the beginning of the
That's right.
presentation.
So Sue's like Taylor Swift, right? So I'm sort of
no. You've given me big shoes to fill in for you after you leave, Peter. That was amazing. It was really, I learned a lot. I always do when I hear you speak.
Thank you. Thank you. And thank you. And I'm so sorry I have to cut out. I just have to go to another talk over here. I'm going to talk about COPD now, which is another risk factor that Sue will tell you about shortly in terms of all these conditions. And I think the vaccination story is a good story in the sense that we're training your immune system. I think if we present it like that, then patients are quite willing to take that on, as opposed to here's another shot, here's another shot, here's another shot. Then it makes it sound like they're just a pincushion. But if we're helping them train, I think that's a good way to put it. All right.
Thanks, Peter. We obviously appreciate you taking the time to speak to us. Let it be the segue of COPD and vaccines, or whatever you're talking about, to bringing it home to vaccines and diabetes, which Sue will walk us through next.
Great. Thank you. Take care.
Thanks so much, Peter.
Peter.